AJ. Really, it's a delight to be here this morning and an absolute honor to be involved in this meeting once again. It's a real pleasure to introduce Professor Derrick Raal. Derrick is well known to all of us. He's given some seminal talks in the context of this wonderful meeting over several years. And Derrick is going to address his real light topic. And he's going to give us an update on managing cholesterol in 2020. For those of you who are online, and I see there are over 200 participants currently, just to give you a little bit of a background with respect to Derrick, Professor Raal is currently the head of the Division of Endocrinology and Metabolism and the director of the Carbohydrate and Lipid Metabolism Research Unit at Wits University. And I must say, one of our seminal researchers and a fabulous clinician. In fact, I've known Derrick for many, many years, and he was my registrar when I began my internship and set a tone that was really quite remarkable. For those who've joined us today, I think the eloquence and the eminence of his research work is quite remarkable. And this year alone in 2020, and I think it needs to be emphasized because it almost has been veiled by the COVID issues. He's had 3 New England Journal of Medicine publications, and just last week, a commentary in Lancet. So we're looking at almost certainly the leading person in lipidology in the world who will be addressing us over the next 15 minutes. Derrick, as always, it's an honor and a delight and an absolute privilege to have you join us. Thank you very much for doing so. We look forward to your talk.
Thanks, Mervyn. Thanks for those kind words, and just thanks to the organizers for being invited to talk at this meeting once again. This is just my disclosure slide, and just to mention, Ethicare has kindly sponsored my talk. So we've had a lot of talk so far, and everyone's concerned about the particle on the left of your screen, SARS-CoV-2. But I'm going to tell you about a much more serious and dangerous particle, and that's on the right of your screen, called LDL cholesterol. So I just updated figures this morning. SARS-CoV-2 has affected about 54 million people worldwide, and there's been about 1.3 million deaths to date. This is what LDL cholesterol has done. It kills about 40% of the world's population, and every year kills over 17 million people. So the CoV-2 epidemic sort of pales into insignificance when you think about this little particle, LDL cholesterol. Many of you have heard me talk before, and these are the big 5 risk factors for cardiovascular disease. I've convinced you previously, and I'll do so again, that I think of the 5, dyslipidemia is the most important, and particularly LDL cholesterol. And the most important evidence for that is the studies, mainly with statins, that have shown that if we can reduce LDL cholesterol, for every 1 millimole we reduce LDL cholesterol, we reduce cardiovascular events by about 24% and mortality by about 12%. And that was the basis of our South African guidelines that were published in 2018. We said that anybody with established cardiovascular disease, all type 2 diabetics, type 1 diabetics long-standing, people with chronic kidney disease, and people with familial hypercholesterolemia should be considered very high risk. And the LDL target should be 1.8 millimoles per liter, with also a reduction of at least 50% in LDL cholesterol. We aligned to the EAS-ESC guidelines, and these were revised very recently in December last year. The main principles are exactly the same. The evidence is that trials at LDL lowering reduces events is definitive. Lower LDL is better, and intensity of LDL reduction should be based on cardiovascular risk, irrespective of the cause. So what's really changed in the latest guidelines, which we have now adopted, is that the targets are going even lower. So once again, it's a 50% reduction, but the new LDL target is less than 1.4 millimoles per liter. So this just compares the two. The targets have come down even further, down to 1.4 for very high-risk patients. And this probably shows it more clearly, sort of schematically, very high risk down the bottom, And those are patients with established cardiovascular disease, diabetics, people with chronic kidney disease. The target is 1.4. And interestingly, in the same guidelines, there's even a lower target, an LDL target of 1, and those are patients with established disease with recurrent events. And that's the LDL we're born with. So I think in the future, this is where we're going to be heading. We're going to be aiming to get our LDL cholesterol to the level that we were born with, and that's an LDL target of 1. So these are very extreme targets, and just how do we get there? So statins have really been around for about 4 decades now, and many people are saying maybe we should all be on them. This is just showing the comparative efficacy of the major statins available, at least in our country. And you can see for that 50% reduction that we need to achieve, the only statins that can achieve that are high intensity doses of rosuvastatin or atorvastatin, which will give you a 50% plus reduction in LDL cholesterol. But one of the big problems is the so-called residual risk. Despite statins, even at high intensity, we don't eradicate atherosclerotic cardiovascular disease. And one of the reasons is this rule of 6. When we double the dose, we don't get double the effect. And above a dose of about 40 to 80 milligrams of any statin, you don't get any further LDL cholesterol reduction. So we can add a cholesterol absorption inhibitor, a drug called ezetimibe. And if we add that to a statin, we can get about a 20% further reduction in LDL cholesterol. There's now a big clinical trial that was called Improve It, which showed event reduction. And importantly, the Improve It study also showed that the main benefit is LDL reduction. So the so-called pleiotropic effects are less important. It's all about getting the LDL down. So with a combination of high-intensity statin and ezetimibe, we can get a 55 to 70% reduction in LDL cholesterol, which is okay for many patients, but not for those with familial hypercholesterolemia. This is some data from Spain, just showing that despite high-intensity statin and ezetimibe, only about 10 to 20% can get to these low targets. So what's on the horizon? And these are the PCSK9 inhibitors, which I'm going to talk about. The newest are the ANGPTL3s, but that'll be at another time. But the PCSK9 inhibitors have just become available in South Africa. PCSK9 was only described in 2003, and it's taken only sort of 15 to 20 years for these two drugs to become used for the management of hypercholesterolemia. The two main ones on the market at the moment are alirocumab, which is the Sanofi drug, and evolocumab, which is the Amgen drug. I'm also going to say a little bit about inclisiran shortly. So just to mention how these drugs work, PCSK9 is secreted by the liver. If it attaches to the LDL receptor, that LDL receptor is broken down and doesn't return to the cell surface. So the current PCSK9 inhibitors are monoclonals. They bind to PCSK9, which means that all LDL receptors are returned to the cell surface and are not destroyed. So this is just one early study showing a single dose of alirocumab at a dose of 150 milligrams per deciliter reduces LDL by about 60%, and the effect lasts about a month. So this is just studies in familial hypercholesterolemia with alirocumab showing that for the first time we can get these patients to this target of 1.8, which has now gone down even further to 1.4. This is with evolocumab, which shows the homozygote patients. They also respond, but about half as well. They get about a 30% reduction. Heterozygous patients, this is a long-term study over 4 years. You can see you get that greater than 50%, nearly 60% reduction, which is maintained for a long period up to 4 years. So just one thing about the monoclonals is it's administered, it binds to PCSK9, but the PCSK9 levels start increasing. So some bright spark said, much as we've been speaking about in previous sessions, is instead of trying to mop up PCSK9 in the circulation, let's try and inhibit the production of PCSK9 by the liver. And this is a drug called small interfering RNA, inclisiran, which inhibits the production of PCSK9 by the liver. And this is a study we recently published in the NEJM, looking at patients with familial hypercholesterolemia, which is given inclisiran every 6 months compared to placebo, you can see about a 45% reduction in LDL cholesterol. So not quite as effective as the monoclonal antibodies, but still halves the cholesterol level. And interestingly, in this study as well, we showed that it didn't really depend on your underlying genetic mutation. All patients responded to this therapy. So this is really going to result in a paradigm shift in the treatment of dyslipidemia. Twice a year injection of inclisiran, which can be given by a health practitioner or by a pharmacist, will halve your LDL cholesterol levels. Other therapies, which we think patients take, will only add to that 50% reduction. So this is really going to revolutionize management of hypercholesterolemia in the future. So just looking at the clinical implications, statins you've got to take every day. We assume patients do, but often they don't. The monoclonal antibodies have to be given 26 days of the year, every 2 weeks, whereas inclisiran only twice a year. And so far, no safety concerns with this therapy. So what's really happened in the last 30 years or so, when I first started in this game, we had nothing for the treatment of familial hypercholesterolemia except for cholestyramine. Then we had the statins, then we had ezetimibe in the ENHANCE study, and now we've got the PCSK9 monoclonal antibodies, and soon we will have inclisiran, the small interfering RNA. So what has changed is from high being bad, we're now looking at lowest is best, and we've really got to try and get patients to these extremely low levels. So just to emphasize and to conclude, one of the very important things is early treatment. We tend to wait until people have their events, and then we try and aggressively lower the LDL cholesterol. This was a very important paper recently published by the Dutch group looking at treatment of familial hypercholesterolemia in children, starting from about the age of 8 to 10. And unlike the parents, the children have a mortality very similar to that of the background healthy population. So if we start early in patients, we can virtually prevent or eliminate atherosclerotic cardiovascular disease. So it should really be the function of medicine to have people die young as late as possible. So in conclusion, LDL is the pivotal risk factor, lower is better, earlier is better, and intensity of lipid-lowering therapy should be based on risk. And to achieve that, we're often going to need combination therapies. Thank you.
Thank you very much, Derrick. Absolutely beautiful overview, succinct, wonderful take-home messages, and I think very exciting elements on the horizon. Whilst we're waiting for any questions to come through, perhaps I could ask you one or two very basic clinically orientated questions that are of relevance to us, and you've emphasized the point of starting early, getting in young, and trying to achieve levels that we're pretty much born with. If you intervene later, how significantly can one regress atheroma with current therapy?
Yeah, it's a very important question, Mervyn. And the studies have shown if we can get the LDL to below a level of about 1.7, we can prevent progression. But if you look at the studies, even with the monoclonal PCSK9 inhibitors, we get regression, but it's 1 or 2%. So it's tiny amounts. So the most important is really to try and prevent the development of atherosclerosis in the future. Animal models would suggest that combination of high intensity statins plus PCSK9 inhibitors plus this new group of drug, the ANGPTL3 inhibitors, which can get your LDL to virtually zero, can cause regression of atherosclerosis, at least in animal models. But I think the most important message is to start early, start young in those patients that are at risk.
What about secondary prevention or even primary prevention? In fact, with the latter being addressed first. I know every year when we do debate this, it's a question that comes up. Secondary prevention, I think we understand. What about primary prevention?
Yeah.
And what
so interesting. Yeah. So interestingly, in the UK, inclisiran is a drug, and there's a big project starting with the NHI looking at treating patients at high risk. So all diabetics, anybody who's had a cardiovascular event, etc., with this drug inclisiran. And if it's used widely, the prediction is you're probably going to save about 30,000 lives per year just in the UK. So in terms of the future, something like this, like a vaccine, as it were, a twice yearly injection, will probably go a long way to preventing atherosclerotic vascular disease, which is still one of the biggest killers. You've probably seen in the latest, in recent Lancet, in terms of cause of death worldwide, cardiovascular disease is now the major cause, not only in the developed world, but also in the developing world.
Thank you, Derrick. Any idea of what the cost of a drug like inclisiran might be to be given twice annually?
Yeah, good question. It's going to be hard to say. The drug was developed by a small company called the Medicine Company. There are only about 45 employees. It was bought by Novartis for $10 billion. So I don't think they're going to give it away. But even if it's 1,000 Rand or $1,000 a shot, because it's only twice a year, it's probably going to be substantially cheaper than the monoclonal antibodies. But I think they've got to make a decision about whether they want to give it to a lot of people and prevent this disease, or give it to a few people at a very high cost. I would think they'd probably choose the former and have the drug available for people that really need it.
In fact, there was a question that has just cropped up from Jessica Trussler, whom you know well, asking, is it feasible and when might this be likely to become available in South Africa?
So I'd probably say it's already now FDA, and it's been sent to the European Union. So I'm probably looking at Europe and the States within 6 months to a year. We're always 2 or 3 years behind. So we're probably looking at about 2023 in South Africa.
Thanks. We need to move on, Merv.
Brilliant. Derrick, thank you so much. As always, enlightening and excellent. Thank you so much for a very meaningful contribution. Take care.